It's my pleasure now to welcome Dr. Ajroud-Driss. Dr. Driss is an assistant professor of neurology at Northwestern University. She received her medical degree from the Medical School of Tunisia, where she completed her neurology residency at the University of Illinois, Chicago, and her neuromuscular fellowship at Northwestern University Feinberg School of Medicine. She is board certified in neurology and neuromuscular medicine. In addition to her role as professor of neurology, she directs the Neuromuscular Medicine Fellowship Program and is the medical director coordinator for the Foundation for Peripheral Neuropathy Comprehensive Care Clinic. The clinic was established in 2008 through the funding of the foundation. Please help me welcome Dr. Driss.
Thank you, Pam, for the introduction. Thank you all for being here tonight. And I will try and go over all that. And thank you for your question, because I'm going to start. Oops. I guess I have to hold it. I'll put it here. So I wanted to go over what peripheral neuropathy is, so to make sure we all are speaking the same language. I will talk about the symptoms of peripheral neuropathy, or PN for short, how we diagnose it, what causes it, and what do we do about it. I do talk fast, so please, if you think I'm going too fast, slow me down. I would not mind. So, peripheral neuropathy comes from the peripheral nervous system. We have two nervous systems. We have three. We have the central nervous system, which is the brain and the spinal cord, and we have this network of highways that connect the muscles, the skin, the joints, all the way back to the spinal cord. And this highway goes from the center to the periphery, is composed by nerves. And also wanted to make sure you understand what a peripheral nerve is. It's called peripheral to compare it to central, because the nerves that go to the face, the nose, are cranial nerve or central nerves. Those, the one that goes all the way down to the periphery are called peripheral nerves. So you can see that the nerve is not different from a cable, electric cable, which has, if you look closely, it has many types of fibers, and then every single fiber has a copper wire, and that copper wire is around that copper wire you have the plastic, the insulation. Well, the nerve is like that. So you have that copper wire, and the nerve is called an axon, and the insulation around it is called myelin. And it's important I'll explain later why it's important to know if the disease affects the axon versus the myelin. So remember, it's exactly like an electric wire, and its purpose is to transmit electricity from the brain, the spinal cord, all the way to the muscles, the nerves, and the skin. We do also have many different types of nerve fiber. We have the ones that go to our muscles. They start in the spinal cord, and they help us move. And we have the ones that go from the joint or the skin back to the spinal cord, and these give information on where our limbs are in space. And these are big, large fiber. They conduct electricity very quickly. We also have tiny nerve fibers that are in the skin, and they are called small fibers. These conduct feeling of pain and temperature. And it's important to know the difference between both. So whatever transmits light touch, our position in space, how we can sometimes walk with our eyes closed, gives information to our brain where our limbs are big, large fibers, whereas the ones that transmit pain, temperature, are tiny nerve fibers. There is another nervous system. It's called the autonomic nervous system. And it's called autonomic because it functions by itself. We have no control over it. And those are the nerves that go to our internal organ, to our heart, stomach, kidneys, liver. They function by themselves. We cannot control them. But they are controlled by nerves. So back to your question. What is peripheral neuropathy? Well, peripheral neuropathy is a generic name that means any disorder, any disease that affect the peripheral nervous system. It, as said earlier by Pam, it does affect a lot of people. And it has many causes. But it doesn't really matter what the cause is because most patients present the same way. You can talk to 10 people and hear 10 different stories about neuropathy, but you can go back and talk to 100 people, they just give you the 10 different stories. So the symptoms are very similar. For example, you're gonna recognize this. Patient complain of burning feet. They will complain of pins and needle sensation, crawling and feeling, right? These sound familiar to any of you? When we talk about this, we call them positive symptoms. So those are abnormal sensations that are present. And sometimes there is, I like this one though. Some patient tells me they feel like their feet have a mind of their own, and that, anyway. And I'm sure you recognize this too. I mean, people have difficulty staying in their shoes. They will bring slippers with them. There is what we call negative symptoms. So some patient may complain about squeezing feeling that they're numb. They feel like they're wearing an extra sock, for example. The shoes feel too small. The feet feel swollen, but when they look down on them, they're not. They look normal. They feel like they're walking on pebbles. And of course, they will complain that their feet are cold, always cold. They don't warm up. I just wanted to point out those kind of medical jargon terms that you may encounter as you read about peripheral neuropathy. And those terms just describe sensation. So paresthesia, for example, is the presence of an abnormal feeling. When this, without any stimulus, you're not supposed to feel anything unless you touch something. But you may not be touching and there is feeling there, and it's abnormal. So when this abnormal feeling is painful, it's called dysesthesia. Now, hyperalgesia is when the pain stimulus is perceived more painful. And allodynia is when any stimulus, a normal stimulus, is perceived like pain. And the allodynia patient will usually complain about the bed sheet touching the feet. I mean, bed sheet touching your feet is a normal feeling, shouldn't hurt, but patient with allodynia, even that touch with the bed sheet create pain, and that's what allodynia is. Some patients may complain about loss of balance. They may not feel they're as balanced as they used to be. And sometimes there is weakness. But usually in most neuropathy, the weakness shouldn't be that important, and we'll talk about that later. And of course, we shouldn't forget about this autonomic nervous system, the autonomic symptoms. And remember, I told you this is the system that innervate the internal organ. So sometimes people may have blood pressure or heart rate issues, so palpitation. They may feel dizzy or lightheaded as they stand up. They may feel fatigue. They may also, when they eat, feel full very quickly. So we call that early satiety, and that is usually due to gastroparesis. The stomach doesn't move fast enough to kind of empty. Patients sometimes may complain of constipation that alternates with explosive diarrhea. Sometimes there is bladder issue, difficulty emptying the bladder, dribbling, feeling of urgency, weak stream, sexual dysfunction, sweating problems, either too much sweating or not as much, or less sweating, or sweating in an area that you didn't used to sweat in, difficulty with temperature regulation, and that's the cold feet that I mentioned earlier. And also sometimes we have skin changes, dryness, swelling, coldness, as I discussed earlier, delayed healing. And that's why people with neuropathy have to take excellent care of their feet and look at their feet all the time. Okay, so after talking about these symptoms, what do we do to evaluate a patient with peripheral neuropathy? So when the patient comes to the clinic, we sit down with them and we take a good history. We talk and we ask questions. it's important for us to know how long have you had neuropathy for. It's very different if you have had it for 10 years versus you had it for 4 weeks. So there is red flags that come to our mind. We want to know about, is it affecting both sides the same way, one side more than the other, the legs only, the legs and the feet? We'll be asking those questions. We want to know about medication. Don't forget that vitamins and supplements have to be mentioned. We ask about alcohol abuse. We ask about family history, foot deformity. Family history is important because there is family history of neuropathy, family history of diabetes. Sometimes people have high arches, and that may suggest that there is a familial neuropathy. And we want to know about other diseases. And then we examine the patient. And as we examine the patient, we're going to check if they're strong or weak. We evaluate their motor function. We will check their reflexes, because usually, sometimes with neuropathy, the reflexes are dropped or decreased. We evaluate their sensation. We use a pin to check for pain. And remember, when we check for pain, we're actually evaluating the function of this tiny fiber. We check light touch, vibration with a tuning fork. We move the big toe up and down. We ask you to close your eyes. And as we move that, we want to know if you know where your big toe is. Is it up? Is it down? Some patients don't, or some patients we have to push it far enough so they can feel it. And that will give us information about these large fiber I was describing earlier. We have the patient stand with his eyes closed to see if the balance is good. We make him walk 1 foot in front of the other, walk on tiptoes, on heels, squat. As we're doing this, we're thinking, what type of neuropathy is it? Is it a motor neuropathy? Is it a sensory neuropathy? What fibers are involved? Big fiber, large fibers? As we're doing that exercise, that help think about a cause for this neuropathy as we're doing that. But sometimes that is not enough. We need to use diagnostic testing. And so the first one we use is called nerve conduction and EMG, and EMG is short for electromyography. So this is a test where usually you go in the hospital, they have a machine, they put electrodes on the skin, and they stimulate nerves with electricity. It sounds barbaric. And then we record the response of the nerve. So this is how we do it. Sometimes we use a small needle, which is actually a microphone that we stick in the muscle to hear the activity of the muscle. And these EMG and nerve conduction study give us good information about, remember when I talked earlier about axon versus myelin, the wire inside versus the insulation? This test will tell us, is it the inside that is affected? Is it the outside? Is the neuropathy affecting only the feet, affects the arms? Does it cause weakness? It will help us also sort out what type of neuropathy it is, and will help with the will help finding a cause. And of course, we're gonna draw blood. And some patients will come to me and say, I went to another doctor and I already took many vials of blood. I'm not going to say what blood we're going to need now, but as I will be talking about the cause, I will point that out. Sometimes we may do a skin biopsy. We have a punch, we take a little bit of skin about the size of a pencil eraser to look at it under the microscope. And this is a normal skin, and you can see the tiny nerve fiber that I told you about earlier. And this is a skin with a small fiber neuropathy. And you see that there is very little nerve fiber left. And you can see it here better, I think, when you have the nice ones, nice nerve fiber, and we don't see any down here. So there is limitation to the nerve conduction study I talked to you about earlier, this one. This test examines the very big, large fibers. So if somebody has a small fiber neuropathy when only the tiny nerve fiber are affected, this test may be completely normal. So that's why we go and get a skin biopsy to prove that diagnosis. Well, Pam mentioned that there is 100 causes of neuropathy. That is correct. There is so many causes. And we call it idiopathic when we don't know. That is true. So I'm going to go over the most frequent causes of neuropathy. And it's not because you have one neuropathy, one cause, you cannot have another. I mean, some people have many reasons for neuropathy. I just start with diabetes because it's the most common cause of neuropathy, diabetes or glucose intolerance. So 16 million patients have diabetes, which is a big number, and about 50% of them will develop neuropathy at some time. And the risk of neuropathy will increase if you, with the length of the diabetes. And by the time people have other organ involvement, kidney or retina, they will definitely have nerve involvement. Not all diabetic are aware that they have neuropathy. A lot of patients that I examine don't know it unless I examine them and I say, oh, you have neuropathy, and they never thought they did. So not all neuropathies are painful. And what causes neuropathy in diabetes? We really don't know exactly, but we know that the increased blood sugar is probably messing up the metabolism of the nerve itself. We think there is a role for inflammation, for free radicals accumulation, and for vascular problems. And as I said earlier, it's not because the patient has diabetes that he cannot have any other reason for the neuropathy. So we do check for other reasons. And what about this glucose intolerance or pre-diabetic state? What is that? So when people are overweight, they develop insulin resistance, and they do not clear blood sugar from their bloodstream as quickly as normal weight people do. So usually those patients will have normal fasting blood sugar, but after a meal, their blood sugar will be higher than it should be. And that may damage the nerve. But also those people, because they're overweight, they may have hypertension, high triglyceride. They may also have other reasons that will damage the nerves. So how do we diagnose diabetes and glucose intolerance? We get a fasting blood sugar. We can do a hemoglobin A1C. Hemoglobin A1C tells us about the blood sugar control in 3 months prior to doing the blood test. And sometimes we do the 2-hour glucose tolerance test. That is, we give something sweet to drink and check the blood sugar 2 hours after. We want to see if when we challenge the system, will the blood sugar goes back to normal. And the treatment of diabetic neuropathy or in glucose intolerance, it's very important, strict blood sugar control. And that's through diet, exercise, and blood sugar lowering drugs. Nutritional deficiency. The main one is vitamin B12 deficiency. It's very common, especially in older people, because they develop an atrophic gastritis and they may not absorb B12 well. Also, we see it in patients who are vegetarian because milk, meat, and eggs are a primary source of B12, and also in pernicious anemia, which is an autoimmune disease. B1 deficiency is not very common. We used to see it in alcoholic. B6, you have to be aware of it. A lot of people take supplement, and it's important to make sure that when you take B6, you don't take more than 100 milligrams. Because B6 deficiency can cause neuropathy, but B6 toxicity can cause neuropathy too. Vitamin E deficiency is a rare cause of neuropathy. It's familial. We saw in the video the gastric bypass surgery that causes malabsorption of nutrient, and other malabsorption diseases like Crohn's disease, celiac, people with chronic diarrhea. So what we do here, we'll have to have a blood test to check for these vitamins, and the treatment is easy. You just give them back those vitamins and hope that the neuropathy recover. It does sometimes. Autoimmune diseases. So I just wanted to show you how autoimmunity develops. And you know that when we are sick, we have a flu, there is a bug in our system, our body develop immunity, and our body does that by having these B cells secrete antibodies. And these antibodies, you can see them here, they're supposed to go and stick to that germ and get rid of it. But sometimes there is a receptor on that germ that look very similar to receptor on our nerves. And in the process of getting the body rid of that bacteria or virus, the body destroys its own nerves or other tissue, and it's an autoimmune disease. Usually autoimmune neuropathy are mainly motor, so patients have weakness. There is the Guillain-Barré syndrome when patients develop acute weakness in about 2 to 4 weeks. If it's more chronic, we call it chronic inflammatory demyelinating neuropathy. People will have difficulty climbing stairs, standing, they can even be completely paralyzed. And sometimes there is inflammation of the tiny vessels inside the nerve, and that's called vasculitic neuropathy. There is also an autoimmune sensory neuropathy and autonomic neuropathy, but those are rare. That's when we sometimes need to do a lumbar puncture, where we get the fluid from, we have to check the spinal fluid, we have to do blood tests, and we have to do the EMG. And the EMG will be very helpful in showing us that the problem is actually the outside of the nerve, not the inside. And the outside of the nerve being attacked, the transmission of electricity is going to be very slow. And those are treated with immunosuppressant. So this is kind of a different area that you probably don't have, but I thought it's important that you know about. Infections can cause neuropathy too. Shingles, hepatitis C, HIV, Lyme disease, leprosy in people who are in endemic area, not here in the US though. We'll have to do blood tests, check for the serology, and also here the treatment will be directed to the cause. We'll use either antiviral agent or antibiotic. Now in cancer, I divided cancer between solid tumor like breast, lung, ovarian, and hematological cancers. And hematological cancer are called lymphoproliferative disorder. So I want to point out this example here. We see there a mature B cell. It's a type of white blood cells. It's producing antibodies, so it's called a plasma cell. And those antibodies, as we saw earlier, are attacking that germ and destroying it. But sometimes that white blood cell multiply and makes clones of itself, and it's called a monoclonal. And it secretes a lot of these antibodies that we call an M protein. And this M protein could be an IgA, an IgM, or an IgG. And if the M protein is low, we call that, it's a mouthful, MGUS, or monoclonal gammopathy of unknown significance. But if it gets to a certain level, we call it multiple myeloma. Well, MGUS is very common in people above the age of 60. So, and it's very common it's 1% in general population, but 10% in patients with neuropathy. So we have to look for it. And once we find it, we have to keep a good eye on it because we don't want it to go all the way to multiple myeloma, which is a blood cancer. Oh, sorry. Other blood cancers, Waldenstrom, B-cell leukemia, lymphoma. Sometimes that M protein is a light chain, and we have amyloidosis. I don't know if you ever heard of that. Now, in solid tumor cancer, how do we get neuropathy? Well, I mean, the main thing is chemotherapeutic drugs. And those are highly toxic drugs that are supposed to kill the cancer cells. But unfortunately, in that process, the nerve cells that goes from the spinal cord all the way down to the feet, we call them sensory nerve cells. Their cell body, or sensory neuron, is an area where the blood-brain barrier has hole in it. And that's what makes the sensory neuron actually more vulnerable than the motor neuron to these drugs. I mean, the main culprits are vincristine in leukemia, lymphoma. We use them also for solid tumor. Cisplatin and their derivative, Taxol. Thalidomide is used in multiple myeloma and sometimes in autoimmune diseases. And bortezomib is Velcade, is used mainly in multiple myeloma and lymphoma. So because the blood-brain barrier in the sensory neuron is not as strong as elsewhere, those drugs go from the mainstream and attack these neurons. It makes them more vulnerable. And that's why people will have more sensory problem than actually motor problem. But sometimes we can get neuropathy in cancer by this mechanism, paraneoplastic neuropathy, Well, this is a little bit similar to the autoimmune mechanism I showed you. When the body recognizes that there is a cancer cell and produce antibody to destroy the cancer cell, but as it's doing that, it will destroy its own nerves. It's rare, but it gives a sensory neuropathy that's so severe that people cannot even stand. They have a lot of difficulty with balance. And sometimes the tumor itself infiltrates the nerves, and you get a direct effect that way. Toxins, alcohol is the main one. Sometimes people don't realize how much they drink. So anything more than a glass of wine a day will be a lot of drinking for the nerves. Heavy metals, arsenic, lead, mercury. I mean, if you work on a farm, pesticide, thallium. Thallium causes also hair loss. Arsenic too does cause hair loss with the neuropathy. And then the laughing gas when you go to have a dental anesthesia. But that is usually dangerous for people who have low B12. It may precipitate a neuropathy. Drugs, antibiotics can cause neuropathy, antiarrhythmic, HIV drugs, anti-seizure medication, a long list. Statin, we don't know. It's controversial if statin do cause neuropathy. But with these drugs, any drug could cause neuropathy. If you start the medicine, you have symptoms, you take the medicine away, the symptoms go away. Every person is different. I mean, to be sure, if you reintroduce the medication, you have the symptoms again. And that's how you know that the drug is actually causing a neuropathy. Treatment. It's very important to treat the cause. By treating the cause, we help to either stop the damage or reverse it completely. But sometimes we can't treat the cause because we don't know it, and we are stuck just treating the symptoms. It makes sense to treat the cause, as I said earlier, the diabetes, the infections. So that's why we do this detective work of trying to know what the cause is. But if we don't, then we have to treat the symptoms. And we do not have a lot of options. So we have to treat the pain, the cramps, the depression, poor sleeps that come with the neuropathy, and also don't forget the autonomic symptoms. I'm not going to talk about all this. I will concentrate on the pain. So to treat the pain, we use anticonvulsant, we use antidepressant, narcotics, or topical medication. Those are the big category of drugs that we use. So why do we use anticonvulsant, anti-seizure medication? Well, these anti-seizure medication, they act on the calcium or the sodium channels in the nerve and gate the transmission of pain. So can't stop, they make the brain not transmit, make the nerve not transmit the pain. I'm sure you're all familiar with Neurontin or gabapentin and Lyrica or pregabalin. Both medication have to be started low, titrated very slowly, and what is low for you may not be low for somebody else. I mean, if some people may tolerate 300, some other may only go by 100, a day. So you have to do it very slowly. And the same for pregabalin. You can even start lower than 50, 25, and go up very slowly. And that is because these medications cause side effects. They cause you to be dizzy, sleepy, forgetful. They give you weight gain, the ankle swelling. So I give my patient freedom in titrating their medication. I say, do it the way you can. One pill a day, one pill a week, whatever you can tolerate is fine. The difference between Neurontin and Lyrica, I like to use Neurontin because it's been around for a long time and it's cheap. Lyrica will allow you to titrate the medication faster. With Neurontin, it may take a longer time to get to the dose you want to get to. The other anti-epileptic that you see down there, Trileptal, Topamax, and Lavictal, I don't use them as frequently, but they do have their effect on pain. And whatever works for one person will not work for the other. I mean, people are different. So if one medication didn't work, if you get it to the dose that you wanted and it didn't do any effect, you have to go and try something else. Antidepressant, why do we use them? Antidepressant, they modulate the level of neurotransmitter in the brain, and that's how. And these neurotransmitters transmit pain. So by doing that, they may decrease the feeling of pain. So you're aware of Cymbalta, amitriptyline. Nortriptyline is like amitriptyline, but has no sedating effect and affects her. And again, they do unfortunately have many side effects. They're all the same. They give you that drugged feeling. They give you nausea, dizziness, sleepiness, or insomnia for others, constipation, weight gain, all that. Opioid. So if the first ones, if the anticonvulsant didn't work, if the antidepressant didn't work, and we can combine them. I mean, there is nothing against, we can do that. Then I usually will use opioid. I will not use these by myself. I will not prescribe them. That's the point where I ask my patient, okay, we have to go and find a pain doctor who will work with us and prescribe those medication. The short-acting ones are fine, like the Ultram, Tramadol, or codeine. Those I can prescribe, and those are supposed to be used when you have severe pain. The rest, the OxyContin, the fentanyl patch, the methadone, usually that's up to the pain clinic to do that. And I really don't have that many patients who require this kind of medication. And of course, again, they all cause side effects. The alternative is to use topical medication. And topical, you may put it on the skin, like lidocaine patch. Those are nice because there is no absorption in the bloodstream, so their toxic effect is very, very low. Lidocaine patch work if you have a very limited area of pain. You can put the patch on it. Remember to put it for 12 hours and take it off. Don't put it all 24 hours. It stops working. Capsaicin is actually that substance in red pepper that makes your mouth tingle and burn when you eat it. And you have to wear gloves to apply it. And that is supposed to deplete the nerve from the substance P. And substance P transmits pain. When you don't have substance P anymore, you don't feel pain. So after you get that kind of burning initially, the pain decreases. Remember not to touch your eyes with it. It burns. So what new treatment is there, out there? So for diabetic neuropathy, they have the alpha-lipoic acid. A lot of the trial for pain are done on diabetic neuropathy, just because diabetic neuropathy is so common. So alpha-lipoic acid, when they used it initially intravenously, it actually showed a nice reduction in pain. And they did a long-term study, 4 years with it, that demonstrate that it's really safe to use with maybe some improvement in pain. I think we need more study to know if it does anything or no. I do prescribe it to my patient if they want it. And I just ask them, tell me what you feel. Do you feel any difference? It's a potent antioxidant. That's what it is. There is a trial going on using dextromethorphan, which is a cough syrup with quinidine, that is being currently tested in diabetic neuropathy. We don't have the result of that one yet. In diabetes, we also used growth factor. Remember, I told you that the problem is that we want to grow nerves back, and we also want to grow blood vessels. So there was trial in the past using nerve growth factor and neurotrophin 3, but unfortunately they did not show any effect. Recently, there was a trial that used VEGF, or vascular endothelial growth factor. The purpose of it is actually to grow more blood vessels, and that will bring more nutrient to the nerves. It really did not, it showed that we can do that, because what we do is we inject it directly in the cuff, and it didn't have many serious side effects, but the effect of on pain wasn't clear. We actually down at Northwestern have just finished a phase 1 study using hepatocyte growth factor, another type of growth factor, in patients with diabetic neuropathy. We are hoping that we're going to decrease the pain and help regenerate nerves. The result of the phase 1 study were very nice. Patients tolerated the drug very well. We only had 12 patients, and they did have reduction in pain, but we can't really tell. We have to go and do a phase 2. And I don't know if you guys understand what phase 1 drug study mean. A phase 1 is when we use the drug to show it's safe. A phase 2, we do it to show, we want to demonstrate that the medicine is effective, so we use it on a bigger number of patients. And a phase 3 is really what the FDA wants. It's when you use the drug on a bigger cohort of patients to show that it's effective. There is medication that are being tried during the chemo to see if it will prevent peripheral neuropathy as the patient are getting chemo. So calcium and magnesium infusion, glutathione, glutamine, carbamazepine, vitamin E, alpha-lipoic acid, and those either showed benefit in small studies or in animal models. So we really need to have big studies so we can prove that these are working and they will become standard of care. In patients with peripheral neuropathy, there is also a trial testing the use of topical amitriptyline, ketamine, and baclofen in peripheral neuropathy. We don't have the result of that yet. And the same for alpha-lipoic acid and acetylcarnitine. Remember, most of the drug trials are done in diabetic neuropathy, so people want to do them also in chemo-induced neuropathy, so they have FDA approval for that. Sometimes if you don't have FDA approval for a drug, your insurance company may not reimburse it, even if we know that it works. So they're doing that with the Efaxor and the duloxetine, which is Cymbalta. So exercise. What is the benefit of exercise in the treatment of any type of peripheral neuropathy? So exercise improves strength, improves flexibility, endurance, balance. It can only help patients with peripheral neuropathy. The problem is that patients with neuropathy sometimes have a difficulty walking or putting pressure on their feet. So we have to be creative and come up with idea to exercise either in a swimming pool or recumbent bike, elliptical machine, to overcome that. What is the role of physical therapy? Physical therapy is very important when there is any difficulty with balance. When they work with you on balance and gait, most of my patients had really improvement in their balance. So it's important to consider. We are fortunate because we do have a physical therapist in clinic who will go and evaluate the balance of our patient and also helps us prescribe exercises that will be adapted to the patient need. If they have difficulty moving, they will find a way for them to kind of exercise. Diet, what's the benefit of diet, or is there a specific diet for peripheral neuropathy? I was surprised to find out how much people don't even know what the meaning of healthy diet is. There is no peripheral neuropathy diet. You just have to be on a healthy diet, low in sugar, on white sugar, and you remember to eat the rainbow. On your plate you have to have vegetable and fruit that have colors in them. Those are the ones that are rich in antioxidant and nutrient. That's where, what it is. You don't need more than that. And we are fortunate too to have a dietitian in the clinic who helps with that. Patients always ask me about alternative medicine. They want to do acupuncture, they want to do many other things. I would caution against that. Insurance does not pay for those things. They tend to be expensive. And I think it's important because there is now integrative medicine center to go to those places where you have a doctor who has a team of acupuncturists, chiropractor, massage therapists. They could kind of help you get the therapy you need. Supplement can be dangerous. Some of these herbs may have toxins in them, so make sure before you start anything to talk to your doctor about that. And again, what is the role of a multidisciplinary clinic like the one we have? We really did not do formal research to see if the fact that the patient is seen by the neurologist, the dietitian, the physical therapist, the social worker, does that make him feel better? We don't know, but the feedback we're getting from our patient, it really helps. We try to get a holistic approach. Yes, you are hurting, but what can you do to do what you need to do during the day? That kind of thinking. So again, Pam did a good job talking about the peripheral neuropathy registry. Patient with peripheral neuropathy, if they want this to change, if they want cure, they have to go and get involved in research. It's very, very easy to get a patient with Lou Gehrig's disease, which is a fatal disease, to be involved in research. It's very difficult to enroll any patient with peripheral neuropathy in research. That is understandable. Lou Gehrig's disease is a fatal disease. If you don't do anything, people die. Neuropathy is different. It's a nuisance, but so far has not killed anybody. But it's important for patients with neuropathy to change that mindset and be more involved in research. So Pam talked a little bit about our research registry and what are we trying to do with that? We are trying to examine the patient the same way, take the exact same history, do the exact same exam, do exactly the same blood test, and then categorize our patient and go back and try to understand why did that have pain? Why did the same person with the same age, the same characteristic did not have pain? We're going to collect blood. We could go back and sequence genes that differentiate people, that show us that some people are more kind of vulnerable to things around them in the environment, or more vulnerable to toxins around them that we know about. I quickly mentioned our diabetic neuropathy study, where we are using the hepatocyte growth factor. And Dr. Allen, another doctor in our clinic, is doing an alpha-lipoic acid study in patients with that are at risk for Taxol-induced neuropathy. And that's it. Any questions?
Protein, which rebuilds the body. How important is that, and what range would you say people should have?
Well, again, you have to have enough.
Can you repeat the question? I can't hear back here.
She was asking about the role of protein. How much should you have? And that is important in rebuilding the body. I do not recommend people take protein shakes. I think you have to have your protein as part of your regular diet. So if you're, but that's it. There is no set amount of protein to be having. I mean, usually you count like a gram per kilo, I think something like that. If you're about 70 kilo, you have to have 70 grams of protein.
Okay.
But there is no definite amount that you have to have for your neuropathy. The only thing is to make sure is for people who are vegetarian, they may lack B12 if they're not getting enough protein. So they have to make sure they get it from other sources, or get B12 supplement.
Well, the sublingual works better for the B12, does it not?
I don't know. If the patient are deficient, I prefer to do it IM and check it. I'll do IM for 6 months, check it in 6 months and see. If the patient are not deficient and they want to maintain their level, it's okay to get take the B12, the sublingual B12. But if their B12 is really, really low, I think it's better to just get it IM and make sure it's intramuscular. Yes, with a shot.
Ouch.
Yes. Yes.
I'm interested in knowing about any treatments for neuropathy that is not painful. It's just the nerves are very loud and interfere with the feeling of the surfaces below.
So the question is finding a treatment for neuropathy that is not painful. Not painful, right? That's your question. And that's a very good question. Currently, the treatment that we have is mainly for the symptoms. Remember the pills that we use. If you have numbness more than anything, the numbness tend to impair the balance, so you may want to make sure get the balance checked. There is no treatment that we can give you now that will help regrow your nerve so your balance gets better, resolve that numb feeling. But we're working on it.
Okay, nothing to regrow there.
We're not there yet.
Okay. Does the body have the ability to heal?
Yes, the body does heal.
We
That's
just don't know how.
Well, it's important. That's why taking the cause away sometimes helps. If you find the cause for the neuropathy and you treat it, you take the offender away, the body can heal itself and the neuropathy can get better if not enough damage happened to the nerve. It does improve. So sometimes a lot of chemo-induced neuropathy does get better after a while. Yes, go ahead, please.
That was sort of my question, does the chemo-induced neuropathy, does that eventually heal, or can that?
It depends. It's difficult for a single person to know where they're heading. You know, every person is different. Everybody's ability to heal is so different. So if you ask me, will my neuropathy go away? I will tell you, I don't know. But yes, there is a possibility as you take the drug away that the nerve will grow itself and after a while can get better or completely go away. But sometimes it doesn't. And it's very hard to know which one is the one that's not going to get better. Yes? Is acupuncture beneficial? I don't know. I ask my patient and I get different answers. I have patients who say yes, it helps, and I have patients say it doesn't help at all. I think people are different. If you want to try it, go ahead. And you let me know. Send me an email. It,
familiar with TENS?
TENS units.
Yeah.
Well,
Recommend that?
a patient with back pain use that. I'm very open-minded. If my patient want to try something, if it's safe, I say, go ahead, try it and let me know how it works. I mean, a good example for that is the infrareds. I was about to buy a machine and put it in the clinic because I had patients so kind of loving it, but then I had patients who hated it and didn't do anything for them.
And what is that treatment?
It's infrared treatment. Some of the physical therapy places have it. And I don't know, there was studies that showed it has an effect and studies showed it didn't.
No, I was referring to TENS, the electrical stimulation.
Yeah, I heard that. Where would you put the TENS?
Well, I put it on my leg, on my legs and my feet. It does help.
Well, I mean, sometimes even brushing, applying a counter stimulation, making the nerve busy, feeling something will help with the pain because they will forget about the pain for a while. So counter stimulation sometimes helps.
I'm thinking of reflexology then also too.
You know, the mind is very potent, so you have to use the mind as much as you can.
Absolutely.
Yeah. Yes, please. Go ahead.
My wife here has tried that infrared thing,
Uh-huh.
and
Did you like it? Didn't do anything?
Not yet. I mean,
Yeah, I mean, you know,
the therapist that I go to, he wanted to try it.
right. It doesn't hurt. It's okay to
I
try.
haven't done it a lot, but,
You know, I prescribe the same drug to one person. It's miraculous effect. Go to the next person, doesn't do anything, and cause severe side effects. People are very, very different. So just do what feels good. Yes.
I'd like to know a little bit about nerve biopsies. When do you order something like that, and what does it tell you?
Okay, that's a very good question. We don't do nerve biopsy as often. So when we suspect, for example, that CIDP, an autoimmune disease, and we don't do it now as much as we did in the past. To prove the diagnosis of CIDP, we may have to go and do a nerve biopsy. But we do nerve biopsy if we suspect a vasculitis or an inflammation of the nerve. To do the biopsy, we want the nerve to be completely dead. So when we do the nerve conduction study, we don't get any response. So we take a dead nerve because if you take a live nerve, then you have severe numbness and pain there for a long time until the nerve heals. So there isn't many reasons for doing a nerve biopsy, but the main one is for vasculitis because we're going to commit patient for immunosuppressant medication for a long time. And we want to have a proof for that before we move ahead. Yes.
I had a spinal fusion in 2005, and I was suggesting my doctor to someone else lately, and I went back to his website, and he is experimenting with stem cell research now and working with the spinal fusions. Is stem cell research something that we can think about in peripheral neuropathy? Is it any way that any of that could ever be beneficial, or is that being looked into at all?
Stem cell is being looked into. It's not ready yet for use. Stem cell is being looked into in all the neurodegenerative diseases, and sometimes neuropathy may be a premature aging of the nerve if we don't find anything. I can't tell you exactly in what regard, but people are thinking. I mean, there is. Stem cell research is being done for peripheral neuropathy, and sometimes it's done when the nerve is transected to kind of regrow nerve back, but we're not there yet. Yes.
Does the removal of lymph nodes under the arms when you get breast cancer affect it in any way? Affect the
Does-
neuropathy in any way?
Does the removal of lymph nodes affect the neuropathy? Neuropathy where? In the feet or in the hand or in the arm?
Any place?
No,
Yeah,
I'm
yeah,
not.
yeah.
I'm not really aware of that.
No.
No. Yeah. Yes.
Is a shingles vaccine a good idea for seniors in general and for neuropathy patients in particular?
I can't really answer that question. I don't know. It is a good idea for older people to prevent shingles. Yes. Yes, please.
For cancer patients, is motor neuropathy more frequent than sensory neuropathy?
It's usually the opposite.
It's the opposite.
It's the opposite. It's sensory neuropathy more frequent than motor neuropathy. Yes. Yes, please.
Why does water aerobics tend to help the symptoms in your feet?
I think water aerobic helps because it takes away the pressure So your body is carried by the water. You're not putting pressure on your feet, and that kind of you move. And usually after you do any kind of exercise, you're euphoric. You secrete more of the happy hormone, so you feel better anyway. Yes, please.
Okay.
Yes.
Okay. I was interested in the Cymbalta and Lyrica combination.
Uh-huh.
I've been currently on Lexapro and taking Lyrica,
Uh-huh.
and Lyrica seems to be falling off in its effectiveness. So it's been suggested that I change from Lexapro to Cymbalta.
Mm-hmm.
What's your take on that?
I don't know. I don't know because you really don't know which one of the two is working. So she's asking. She was on the combination Lexapro and Lyrica, feels that the Lyrica is not working. She was asked to change Cymbalta and Lyrica. I'm not aware if the combination makes one or the other work more. So I don't know that actually changing will make a difference. So what dose of Lyrica are you on?
900 a day.
Wow.
Yes.
Yeah.
It's not.
Right. Well, the other thing you have to remember that those medications work on the pain or the positive symptoms. When you have extra symptoms, when you have tingling, when you have pins and needle sensation, they do not work on the feeling of numbness. They may not be helpful that way. So remember that. Those are called negative symptoms, and these medications may not help with. There is a 3-month wait list. I'm sorry for that.
There's a 3-month wait for what?
For our clinic, for an appointment, new patient in our clinic, yeah. We're only 3 doctors. Well, actually 2.5. The other doctor with us, no, that I didn't mean it that way. She's only part-time because she's really doing research in painful peripheral neuropathy. So.
Now, you had mentioned earlier, and I can't quote you exactly, but you said it's rare, but not being able to bend over and with the knees.
The weakness.
Yeah.
Having significant weakness. Sometimes patients may have some weakness. They may not be able to walk on their heels, for example, or tiptoes. But to have enough weakness so you cannot raise from a chair, you cannot climb stairs, that's a lot of weakness. And we have to look for another type of neuropathy. That's what I meant.
Okay.
It's not the typical distal symmetric. We call it length dependent because it affects the longer nerve first.
And what could cause that or not know?
Well, the motor one, the one with the motor, you mean? Or the other one?
With not having the ability to go up the stairs, the weakness.
The weakness. Well, there is many causes for the weakness by itself, but one cause will be the autonomic neuropathy, like the not autonomic, autoimmune. I'm sorry, like the CIDP or Guillain-Barré. Those can cause significant weakness. Okay. Yes.
Will any type of circulatory issue kind of exacerbate or have a synergistic effect with things like chemotherapy or diabetes to cause more nerve damage?
Well, patients who have peripheral vascular disease, they do have neuropathy because their vessels are clogged and the nerve are not getting the nutrient they need. If you have one neuropathy and if you have chemo-induced and you end up developing diabetes, the neuropathy is going to get worse. So having one cause is always better than have multiple causes for neuropathy.
Is congestive heart failure kind of like one of those? I would imagine that.
Well, congestive heart failure, because the heart is really not pumping enough blood to go to the periphery, and they tend to have swollen legs, so that makes things worse.
So even if it's like under control, is it still a high-risk situation? Or?
Well, in order for your nerve to heal and be healthier, you have to keep your whole body healthy. So any disease that you might have may make the neuropathy worse. So the body as a whole have to be healthy. So it's a combination of things, yeah. I'm sorry, you had a question.
It's okay. Neuropathy starting your feet and legs, okay? Sometimes it takes a long time to really develop where you really have severe symptoms.
Mm-hmm.
But yet it took a long time to develop where it's gotten to a point where it's a little more noticeable,
Mm-hmm.
okay? Why could that take so much longer and then all of a sudden within like a year you feel it a lot more in your hands? All of a sudden now it's in your hands, but it didn't take years to get there.
Okay,
Later,
yeah.
It might be obvious.
So the nerve that go from your spinal cord all the way to your feet are about 1 meter tall. They're very tall, long. And you have to imagine it like a highway, or so the nutrient to go from from the cell body all the way down to the feet, it takes a long time. So that's maybe a reason why the feet start with the disease first. But as the neuropathy crawls up, when it gets to about the knee, that's the length of the nerve that goes from your neck all the way to your arm. So when it gets to the knee, that's when people start feeling it in the arm. It's just a length issue. Yeah. It may seem like all of a sudden when actually it was kind of creeping a little bit. Yeah. That's about the length that goes. Yes,
So why
please.
can't they stop that progression?
Well,
I mean, it's like if you start with sensory and then you move into the motor and then
Uh-huh.
probably the other. But isn't there any way to stop it? That's what I don't understand. So I just-
well, we're not there yet because we don't have research in the past year has, I mean, people have been very, very involved in treating pain, not growing nerves back. The only way we can stop it if I can give you a pill and it grows your nerve back. We cannot do that because it's very hard to do. We don't know how it does. We're trying to understand how does that nerve die. The nerve dies by many, many, many ways. And if we put it on a petri dish, we look at it, it dies. It's not the same way it does in the body. So we're trying to understand the mechanisms of what we call axonal degeneration. And then we're trying to understand how we can reverse that and how we can make the nerve grow. We don't know. So there is not, like Pam said, enough funding for research. NIH does not fund peripheral neuropathy that much because it's not a lethal disease, really. And it's not, somehow, I don't know, I don't want to get into the politics. And then also because neuropathy patients in general are not very involved with research, there wasn't a movement to actually say, okay, now we have to really concentrate on trying to understand how we grow these nerves back. And with money, we can fund research projects and we can develop molecules that may help us do that. I mean, that's the limitation, really. Yes?
She would like to know if neuropathy can affect the vocal cords.
There is forms of peripheral neuropathies that are hereditary, that do affect the vocal cords. Usually the vocal cords are not affected by the regular neuropathy that we we talk about, but if the nerve that goes to the vocal cord is somehow cut, or it's a nerve, so it can be vulnerable to many things. But there is a type of hereditary neuropathy that have vocal cord involvement with them. Yes?
Are there certain foods one could eat to help your nerves to kind of come back to where they should normally be, like certain foods to eat to keep your cancer in remission?
No, just healthy food and the rainbow again. Food with colors have antioxidant and nutrients. So you want to make sure on your plate you have a wide array of colors. And those are the good food to have. Yes?
Addressing foods again, is there any evidence that artificial sweeteners contribute to?
I don't know. I don't do them. I don't use artificial sweetener. It's just, I'd rather have a little bit of sugar than a lot of artificial sweetener.
People that have it not use them?
I do not do that because I don't think the evidence is there. I mean, if you'd rather have just a little sugar is better than a lot of sweetener.
And your take on vitamin D3?
I don't know. When I went to my doctor, I was hoping that I won't have vitamin D deficiency because I will tell her I don't want. No, I didn't. So I didn't have to worry about that. I don't know. It's a new thing that we're finding in many patients. I don't think there is enough research that we know that adding vitamin D will help with neuropathy. There is vitamin D and multiple sclerosis. There is some connection. But with neuropathy, I don't think we know that much yet.
Because we had 3 different doctors here. One Dr. Block, also with cancer involvement too, and also another gentleman here too. And they felt that that reading should be 70 or 80.
Yeah.
Not that 30 in almost everybody.
I would refer that to the primary care physician and have them, if they decide they should treat it, that's fine. Yeah.
Where's that test? So your test came out okay?
Yeah, my test came out okay. Yes.
How does it affect the lungs? Can it affect the lungs?
The neuropathy? Usually neuropathy does not affect the lungs. No. But sometimes the lungs, the phrenic nerve, innervate the diaphragm. Again, There is neuropathy that are symmetric, affect the feet, and there is what we call mononeuropathies. Because we can develop carpal tunnel, we can develop ulnar nerve problem. There is individual nerves that can be affected by themselves. And sometimes in diabetes, that's more common because nerves are more susceptible to compression. So if the phrenic nerve is involved, then people will have problem with breathing. But usually they don't. Yes?
I'd like to go back to your B6 and greater than 100 milligrams a day.
Yes.
My oncologist has repeatedly recommended 600 milligrams a day of B6.
Well, I would check your vitamin B6 level and see how high it is. Because people are different in their absorption too, so. Yes?
Have you come across anything about, my doctor once said about like blood transfusion or blood recycling thing where you sit for like 3 or 4 days during a week? And do that?
Plasma exchange?
Yes.
Okay, plasma exchange is used in autoimmune diseases. When you see these antibodies that are attacking the nerves, we want to get rid of them. So plasma exchange is only used in autoimmune disease, not in like general peripheral neuropathy.
So that hasn't really been used or
No.
tested or anything?
No, there is no reason for it because we don't know if it's caused by abnormal. It's a very dangerous thing to do. It's not easy. People have to be in the hospital.
Yes,
There is many complications. So we don't do it lightly. Yeah, we do it when there is a lot of weakness. We really suspect an autoimmune process going on. Yeah. Yes?
Do you ever suggest a particular type of shoe for your patient?
Shoe. That's a good question. No, I don't. I think some of my patients like diabetic shoes because they're wide. The box is wide in front, so the toes are not squeezed. No, comfortable walking shoes will be the...
Can I interject?
Yes.
The foundation has a Facebook page, and a lot of these questions, like shoes or acupuncture or different devices people are using, and it's a great way for people to virtually, connect with each other and talk about things that do work and don't. And there's a lot of folks on there that have given recommendations for different types of shoes. So go on there. We also have our newsletter. We put out stuff on our newsletter and on our website as well. And I think Dr. Driss said it very well. Everybody's different, so try the things that may or may not work as long as they're safe. But our website and our Facebook page, again, the community of patients on there, they really share a lot of different information of what's working, what's not working, what they've tried. Dr. Driss said, some people say, like the TENS unit. Some people loved it, others hated it. Final benefit. So, and that's important. So if you leave today, please give Brenda the registration form, and we will make sure that you receive our newsletters and updates, not only just about what we talked about here, but further research that's going on and benefits that we're finding for patients.
Yes, please.
Did the slide that was up there that suggested vitamin B6 should be less than 100 milligrams?
Yes, if you take B6 supplement, make sure you take less than 100 milligram, unless you have some sort of deficiency and your doctor tells you otherwise. Always listen to your doctor, not to me, because I'm not your doctor. Yes.
Is there any topical medication for sensitivity in the fingers?
Well, not really. What works in the finger is doing occupational therapy. I had a patient with severe sensitivity in her finger. She had to put like tape because she couldn't type anything. And doing occupational therapy helped very well with that. So you may want to try that. I think any occupational therapy place, if you tell them it's for peripheral neuropathy, for feeling, because usually they do it for weakness to get people adapted, and
They need an order from your physician.
you probably need an order from your physician. Yeah. Yes.
Yeah, they've done, I know they want to be in a study, and I decided not to be in a study, but the study was going to have where we could have either 12 2 weeks, like 12 times 2 week cycles, and then, or you could have like 6 of the chemotherapy and either this other drug or placebo. What I guess I was wondering is, have they done other studies with out, with the neuropathy about if you just had six treatments?
I'm not. I don't know what trial you are referring to. Are you talking about a trial for cancer?
Oh yeah, this is a trial. I don't know if this is for colon cancer. Mine's colon cancer, but there's a trial that they want me to become a part of.
But is the treatment for the cancer or the treatment for the neuropathy?
No, for the cancer.
For the cancer. Yeah, I'm not.
Okay.
Yeah, I'm not aware of those.
Okay.
Yeah.
Thyroid medications, do they exacerbate the condition?
No, thyroid medication don't. Hypothyroidism or hyperthyroidism, thyroid disease in general, can cause neuropathy. So you have to make sure that your thyroid levels are normal and have
The medication itself is not.
No, the medication itself would not.
Synthroid is not a problem.
Shouldn't be, no, because it's helping you have your thyroid hormone. So, yeah. Okay. Anything else? Well, thank you all for coming.